Hello everybody, we're going to start here with some of the various disorders of the esophagus.
So this is just a schematic of the digestive tract. We'll see this over and over again as we go through the digestive tract and the various disorders. Of course, this is just a schematic. This is obviously not anatomic, but and it's not to scale either. But just to kind of show the various organs and sort of how they're interconnected in the digestive tract. And it's good to know because we want to know how these various disorders, how they interact with the anatomy, and that will help us land a diagnosis. So, some principles of esophageal disorders. So, there are three different things that you want to keep an eye out for when you're making a diagnosis of an esophageal disorder. So, the most common presenting symptom for esophageal disorders is dysphagia. And what dysphagia is it's difficulty swallowing, and that doesn't necessarily mean pain. You can definitely have dysphagia with pain, but dysphagia itself just means difficulty swallowing. So you don't have to have pain. Generally, dysphagia, when we say dysphagia, we just mean difficulty swallowing, no pain. So that's dysphagia. Now, odynophagia is pain with swallowing. So this isn't just pain in your esophagus. This is pain that's precipitated in your esophagus when you swallow. So odynophagia is pain on swallowing. And then there's another symptom that comes up in the esophagus, which is really specific to one disorder, and that's just general pain down the esophagus. A good principle to know is that any esophageal disorder can theoretically lead to signs and symptoms of weight loss and malnutrition, and that makes sense because if you've got difficulty eating, difficulty swallowing, if it's painful, you're not going to eat as much, and so you're prone to weight loss and malnutrition. The three diagnostic modalities that we most commonly use in making the diagnosis, establishing a diagnosis of any esophageal disorder, are the barium swallow, which is an esophagram. It's called a lot of different things: barium esophagram, barium swallow, just plain old esophagram. But this is a technique where the patient swallows a barium containing fluid, and then an X-ray is taken, which will then pick up that barium, so we can see the contours of the esophagus. Esophagogastroduodenoscopy, otherwise known as EGD or upper endoscopy, is an endoscope where we place down the patient's mouth and down the esophagus, and we can go as far as the first part of the duodenum. So this is good for getting an actual visual, a real-time visual of what's inside. It helps us visualize in case there's any kind of specific obstruction, a tumor, if there's something stuck. So that's what EGD is used for. And then esophageal manometry is used to discern pressure within the esophagus, and this is a relatively new technique. So we'll see that come up. Okay, so these are the three classifications this is just how I classify them, but this is how we're going to go over these. Primarily the disorders that primarily cause dysphagia. So we got achalasia, esophageal carcinoma, Zenker's diverticulum, Schatzki's ring, and Plummer-Vinson syndrome. And then the disorders that primarily cause pain. That's going to be diffuse esophageal spasm, esophagitis, and Mallory-Weiss tear. Mallory-Weiss tear doesn't technically cause pain, but it can be followed by something that causes pain. So that's why I put it in that category. It doesn't really fit with anything else. Reflux, that's just one thing, and that's going to be GERD followed by systemic sclerosis, or proceeding from systemic sclerosis. So what is dysphagia? We kind of already talked about this. Dysphagia is difficulty swallowing. When you hear patients talk about dysphagia, if you've never had it before, the the way that most patients describe this is as a pressure in there. It's not necessarily a painful pressure, but it's a pressure that they feel in their throat. And if you've probably felt dysphagia before, or this kind of pressure before, if you eat a lot of food and all at once, and you don't drink any water with it, and you feel that pressure in your throat. That's the kind of pressure that these patients feel in their esophagus. Some will describe it as that the food gets stuck. That's another way to describe it. And a lot of patients will point to a specific location where the food gets stuck. And we're going to see when we talk about esophageal webs and that you can actually have an anatomic position where the food is getting stuck. Dysphagia itself, by itself, is never painful. Now, I'm not saying you can't have dysphagia in a patient who also has odynophagia or dysphagia in a person who has pain in their esophagus, but dysphagia alone does not imply pain. And it's very important to discern from a patient whether this difficulty swallowing occurs with solids alone or with solids and liquids. So some patients will be able to drink liquids, they'll be able to drink water fine, but it's when they eat food that they get their dysphagia. And then other patients, they have equal difficulty with solids and liquids, or roughly the same difficulty with both solids and liquids. That's going to help us differentiate our diagnosis. And the reason this is important is because solids alone versus solids and liquids will help us differentiate as to whether this is an obstruction, which would give us difficulty with solids alone, or due to a mechanical abnormality, which would give us difficulties with both solids and liquids. And then be vigilant for accompanying alarm symptoms, and what these alarm symptoms are basically something that will point us towards cancer. So in any patient that has dysphagia who is over the age of 60, who has anemia, heme-positive stools, symptoms lasting longer than 6 months, or a patient who has unintended weight loss. Okay, so sorry this is a little blurry, but this is how I kind of classify these up into the disorders that primarily cause plain old dysphagia, the disorders that cause or are followed by something that is painful, and then GERD. Let's talk about achalasia. So achalasia is the most common cause of dysphagia, and it's primarily caused by a disordered peristalsis, which results in disordered opening of the lower esophageal sphincter. So as you go down your esophagus, what you have is basically a chain reaction where the esophagus will close at one point and then, not close, but contract at one point and then relax at the point distal to it, or further down towards the stomach. So that allows the food to travel in a very coordinated way. And so what happens if you have disordered opening, or if you have disordered peristalsis, then what's going to result is that as you get down to your lower esophageal sphincter, which is what separates the esophagus from the stomach, you're not going to have the correct electrical activity going into the lower esophageal sphincter, and so the LES is actually not going to open or relax properly. So it's disordered electrical conduction, disordered peristalsis, and the ultimate result of that is a disordered opening of the lower esophageal sphincter. And that's what actually causes the problem, is the disordered opening. And so because you don't have an LES that relaxes or opens properly, food material is going to remain stuck in the distal esophagus, in the lower esophagus, and that's going to result in a sensation of dysphagia, difficulty swallowing. So because this is a disorder of the sphincter itself, nothing is able to get down, not food, not water. And so dysphagia that's due to achalasia is going to be equal to solids and liquids, or roughly equal to solids and liquids. And some of these patients may have weight loss. So the presumptive, you can make a diagnosis of achalasia in patients who have dysphagia with no alarm symptoms. And then in patients where you've made the diagnosis of achalasia because they have dysphagia with no alarm symptoms, then the next step in diagnosis is going to be to get a barium esophagram. And that's just where they swallow the barium and you take the x-ray. And that's going to show the classic bird's beak esophagus. And so here are a couple examples of the bird's beak esophagus. These are two separate patients. You can see here that you have a very dilated proximal esophagus, but the distal esophagus is contracted here. This is the lower esophageal sphincter. You don't have any relaxation of the lower esophageal sphincter. Here you have, right here, you've got barium in the stomach, but you've got very dilated esophagus here because you're not able to get the contents down into the stomach because of the rigidity, the contraction of the lower esophageal sphincter. And here's another example here. So achalasia is affirmed by the barium esophagram, but to make a official diagnosis, you actually have to get manometry. So barium esophagram, that bird's beak sign, will affirm our diagnosis. It's kind of more like a screening. It tells us that this is more than likely achalasia, but you have to get a manometry in order to confirm the diagnosis. Manometry is the most accurate test. But barium esophagram is the first test. So if it asks you which of the following is the best first step in the diagnosis of this patient, then it's going to be barium esophagram. If it asks which of the following is the most accurate test, it's going to be manometry. As far as treating patients with achalasia, the first line of treatment is pneumatic dilatation. And that's just simply where we go down to the lower esophageal sphincter and we dilate that so we can get food down. And that has a pretty good success rate. Another treatment, but not the first line, is botulinum toxin injection. And Botox, what that does is it blocks the acetylcholine receptor, and that results in relaxation of the LES. The last resort, if pneumatic dilatation or Botox don't work, is a surgical technique known as a Heller myotomy, and that's where the muscle is actually cut. And so, but we prefer not to use that because of the reflux that can come from that. So you can go the opposite way where you're getting reflux rather than not getting anything down. So the Heller myotomy shouldn't be done unless you've tried pneumatic dilatation and Botox. But the first line of therapy is pneumatic dilatation. True achalasia is idiopathic. We don't know the cause. I mean, we do know that there is disordered electrical conduction, but what causes it, we don't know. Chagas disease doesn't happen very much in the US. This is an infectious disease, but it can mimic achalasia as far as the disordered electrical conduction. But if you do have achalasia due to Chagas disease, it's not really true achalasia. It's Chagas disease causing the dysphagia. Okay, so now what happens if we have the patient with the achalasia-like symptoms, with these dysphagic symptoms, and they also have the alarm signs or symptoms or history? So in other words, is the patient has what looks like achalasia, but the patient is over age 60, the patient is anemic, they have heme-positive stools, meaning melena, they have symptoms continuously for more than 6 months, or they have unintended weight loss. In this case, you're not going to start off with your barium esophagram. You probably will get a barium esophagram in real life on these patients eventually, but your first step, the best first step for diagnosis in these patients, because they have such a high risk, each of these are risk factors associated with carcinoma of the esophagus. Because esophageal carcinoma is so likely in these patients, we actually want to just skip right to EGD and get that done first. And so we're going to get an EGD in patients with achalasia, with presumptive achalasia or dysphagic-like symptoms, in patients with alarm symptoms. So we get the EGD there. If we see a tumor or we see something that looks like it could be obstructive, then we get a biopsy and we send that off. If it's normal, then that's going to pretty much rule out a carcinoma. And so the patient can then have a barium esophagram, and we'll go ahead and treat them like we would any other patient where we presume achalasia is the diagnosis. So esophageal carcinoma, there's two separate histologic types, and there's two separate associated risk factors that are associated with them, but together they have very similar presentations. So while they're two very separate tumors, they're two very separate causes that cause them, they present very similarly. So esophageal carcinoma classically presents as dysphagia in an older patient, and their dysphagia is more sensitive to solids than to liquids. And really, that makes sense because what you have is an obstruction. You don't have a muscle or a neurological problem. What you have is an obstruction. That's the only thing that's preventing the food from getting down. And in any tumor that you have, you're not going to have a total obstruction. So fluid is going to be able to trickle down, but food is going to have a very difficult time getting down. And so the dysphagia in obstructive causes, namely esophageal carcinoma, is going to be more sensitive to solids than to liquids. So because there's both dysphagia and cancer in these patients, both dysphagia and cancer can cause weight loss. Weight loss is going to be a prominent sign in these patients. So the symptoms are going to be dysphagia more towards solids than to liquids, but there will also be a significant weight loss too. So the two types, sometimes on the USMLE they'll give you a patient's history and they'll ask you to answer which of the following is the most likely diagnosis. The way you're going to know what the most likely diagnosis is based on whether it's cancer is the history of the patient. So squamous cell carcinoma of the esophagus tends to turn up in smokers and alcoholics, whereas adenocarcinoma of the esophagus tends to show up in patients with long-standing gastroesophageal reflux disease. So the reason that, you can look at this as adenocarcinoma. It shows up in the bottom 1/3, and the reason is because of the long-standing GERD. So you get the acid hitting up against the esophagus, you get those changes, those squamous to columnar changes, and eventually you get Barrett's esophagus and you proceed to adenocarcinoma. Whereas with squamous cell carcinoma, it's more directly associated with the carcinogens in smoking and in alcohol. And that's going to be more in the proximal 2/3 of the esophagus, so the upper 2/3. But we have to get EGDs and biopsies for these patients. We can't tell based on history alone. So, as mentioned earlier, patients with dysphagia and alarm symptoms need to have an EGD with biopsy. That's going to help us confirm the diagnosis of esophageal carcinoma if it's present. If we diagnose patients with esophageal carcinoma, then we need to get three things on these patients. One of them I didn't write on here. I'm sorry about that. First of all, we definitely need to get an endoscopic ultrasound. So we'll go in with the EGD and we'll have an ultrasound on that, and that's going to help us stage because it's going to tell us how deep the cancer is. We also need to get a CT because we want to look for abdominal metastases. And then a bronchoscopy will also be useful to check for local spread. Remember that the esophagus and the trachea, the respiratory tract, are not that far apart. So and all esophageal carcinomas spread they spread locally. So we have to keep an eye on that. So we're going to get an endoscopic ultrasound, a CT, and a bronchoscopy on any patient where we've made esophageal carcinoma diagnosis on biopsy. The treatment is unfortunately going to be primarily palliative. We will assess them for whether we can do a surgical resection, and that's primarily going to have to do with how deep the tumor is and how widespread it is, whether or not there are metastases. Surgical resection is going to be the only curative therapy, and generally only 1 in 4 patients will qualify for surgical resection, and out of those patients that go into surgery, about 1 in 5 will actually die from the surgery. So unfortunately, this is not a very curable cancer. So the treatment is going to be primarily palliative, And what we do is we administer 5-fluorouracil, which is a chemotherapeutic agent, and that shrinks down the tumor a little bit. It doesn't prevent the progression of the cancer, but it shrinks the tumor down a little bit to palliate the dysphagic symptoms. And so here I've got, these are pictures from endoscopy, from EGD. This on the left here is a normal esophagus, so kind of a point of reference. You can see if you go down far enough, I think that's getting down toward, this is the upper esophagus, but you can see sort of how the contours of the esophagus look. You know, it's a normal tube-like structure, and you get down towards the sphincter. Now here you've got some different ways that cancer can present. So this is looks like a relatively localized tumor. This is actually an adenocarcinoma. Of course, you can't tell just by looking at it, but you'd need to get a biopsy. But if it's in the lower 1/3, it's more than likely an adenocarcinoma. But this, you can just see it's very the outer tissue looks just like normal esophageal tissue, but you've got this sort of blockage, and so this would be the point where you would get your biopsy. This is a more diffuse tumor, but this is also an adenocarcinoma. So you've got more than one foci of tumor. These are both squamous cell tumors. You can see these two look very similar, but they're both squamous cell tumors. So again, just highlights why you need to get a biopsy. And this is a more localized, larger focus of an esophagus, or of a squamous cell carcinoma. Okay, so off of tumors and achalasia. So now we're going to talk about Zenker's diverticulum, which is completely different. Zenker's diverticulum is a disorder of anatomy, and what happens is that you get a high pressure in the esophagus, and the result of that is that the pharyngeal constrictor muscles will give way. And so when you get a high pressure in your esophagus and the pharyngeal constrictor muscles give way, what happens is you get an outpouching of your esophagus through where those constrictor muscles are supposed to hold your pharynx, hold your esophagus. And so this is not necessarily a disorder of the pharyngeal constrictor muscles so much, but the reason that we bring up the constrictor muscles is because that's the weakest part of the esophagus, and so that's going to be where the esophagus herniates. So really this is just an esophageal herniation, but it herniates through the pharyngeal constrictor muscles. The pharyngeal constrictor muscles are on the posterior side of the pharynx or of the esophagus, so the outpouching is going to be towards the back of the esophagus. Now what happens is that the pouch causes pressure, and so that pressure is going to be felt as a mass. It's going to be felt as a lump, or it could even be felt as food stuck in the esophagus. And the pouch is also going to collect food material, and that's bad for two reasons. One, it can cause regurgitation. And two, it can collect food material, and the food material will rot, and that's going to result in really bad breath. So multiple different things here. You've got regurgitation, you've got severe halitosis, you've got pressure that leads to this dysphagia. And so the symptoms here are going to be dysphagia. The patient will always point to their neck. If the patient is pointing to their belly, this is not Zenker's diverticulum. So the patient will point to their neck. You can get regurgitation. A lot of times these patients, particularly if they've had this diverticulum for a long time, they'll be able to actually press on where the pouch is, and they'll be actually able to regurgitate on their own. I don't know why anybody would want to do that, but some of these patients can do that. If they can do that, that's very particular to Zenker's diverticulum. And then extreme halitosis, and that makes sense because if you have food, sometimes it can be in there 2, 3, 4 days in that pouch, you're going to get some major bacterial action going on there. And so halitosis, I mean, you can imagine if you kept some food in your mouth for 4 days, what it would smell like. You know how your mouth smells if you don't brush your teeth. This is like that, but way worse. This tends to happen in older patients just because the musculature gets a little weaker, but it can happen in younger patients too, but it tends to happen in older patients. The diagnosis is going to be done with barium esophagram, which will clearly show this diverticulum. It will show this outpouching. And the treatment is going to be surgical. It's a cricopharyngotomy, and all we're doing is we're cutting one of the stronger muscles, and that's going to equalize the pressure. I'll show you a diagram of that. But you should know that the treatment is surgical for this. So here's your, so this is just a schematic, but here you got your posterior pharyngeal muscles. And at the weakest point is where you're going to get your, which is the most inferior point, is where you're going to get your diverticulum. So this is just esophagus herniating out through the muscle. It's like any other hernia. And then this is a lateral view. And here you can see on barium esophagram what that looks like. So this is the treatment. You can either do it transcervically or you can go down with this tool. And what you do is you cut one of the stronger muscles, and that's going to equalize your pressure. So that rather than having this little outpouching, if you cut a part of these muscles here, you'll equalize your pressure, and the esophagus won't outpouch through this little tiny hole. Don't worry so much about the technique. USMLE is not going to talk about surgery as far as surgical operations, but you should know that this is a very surgical anatomical disorder. Okay, so Schatzki's ring is a circumferential ring of esophageal tissue that results in a narrowing of the esophagus. So all this is you have your normal esophagus, right? And what happens is with Schatzki's ring, you get tissue completely surrounding the esophagus that narrows the lumen, and it's just basic esophageal tissue. It's outer tissue. It's not. This is not a stricture. So you don't really have that much of a narrowing, but you have a slight narrowing to where food can get stuck, and it tends to be in the Schatzki's ring tends to be in the lower esophagus. You may or may not see the differentiation as far as Schatzki's ring and where it is, and surgeons will like to refer to these as A rings or B rings. The A ring, which is more common, occurs right around the lower esophageal junction, so right around where the esophagus goes into the stomach. The B ring is a little bit more proximal, and it occurs around the squamo-columnar junction, so roughly 3 to 4 centimeters above the LEJ. The symptoms for Schatzki's ring is going to be dysphagia that's sensed around the bottom of the sternum. So usually where the patient says that they feel the food is getting stuck, it's usually a little bit lower than that the food is actually getting stuck. So if the patient's pointing to their neck that they've got the dysphagia, it's not a Schatzki's ring. Likewise, if they're pointing to the bottom of the sternum, it's more than likely a Schatzki's ring, not a Webb or a Zenker's diverticulum. The diagnosis, again here, it's going to be a barium esophagram. This is a mechanical obstruction. So barium esophagams show those just really well. We can see the contours of the esophagus. Once you've diagnosed a Schatzki's ring, then your treatment is going to be an endoscopic dilatation. We'll go in with an EGD, with an endoscope, not with the purpose of visualizing the esophagus, but with the purpose of actually administering treatment, and we'll dilate the esophagus at where that ring is. So here's a very classic Schatzki's ring. This one here appears to be, I can't really tell because I can't really see how many inches this are, but this one appears to be a B ring. And this one here appears to be an A ring. The way you can tell that this is a Schatzki's ring is because you have a circumferential narrowing. You've got a narrowing on this side, and you've got a narrowing on this side. You can't see the side that's pointing at you because this is just a two-dimensional picture, but you know that this is a ring because you've got it on both sides. So what's the difference between rings and webs? So a ring, like a Schatzki's ring that we just talked about, is circumferential, so it's going to span across the entire circumference of the esophagus, whereas a web, it's going to be just in one part. So this is a good visual, and this will help it make sense. So you can see here that this is a ring. Normally the esophagus the lumen would be a little bit wider, but you've got tissue spanning the entire circumference. So this is a ring, like a ring that goes around your finger. It's the entire circumference of your finger. Whereas this is a web. It's not going around the entire circumference. Down here, you don't have anything. You just have tissue that's from this point to this point. So it's not the entire circumference. That's a web. Okay, so what if we do have webs rather than rings? So esophageal webs, as I just mentioned, are non-circumferential outgrowths of the esophageal mucosa. And then a particular disorder that features esophageal webs is Plummer-Vinson syndrome. So this will be a patient who has multiple webs and also has an iron deficiency. So it can be useful in a patient that has webs or has dysphagia to, if you look at their blood work, to take a look at their CBC, see if their hemoglobin is depressed, because that can be useful in possibly seeing, is this something that might be deeper than just basically esophageal webs. So Plummer-Vinson syndrome is esophageal webs, but it's esophageal webs with iron deficiency. Now the symptoms for esophageal webs, and what's going to help you differentiate this from the Schatzki's ring, is that this dysphagia is more upper. It's more in the neck, not so much down towards the stomach. So it's not a Zenker's diverticulum because they can't express they're not regurgitating, they can't express that food from that pouch. Usually these patients could be younger, but it's still in the neck area. So that's what this has in common, but different from Zenker's diverticulum. The way you diagnose this is, again, barium esophagram. And you'll see on esophagram, you'll see the web, I'll show you that. And the treatment is going to be, just like with Schatzki's ring, it's going to be endoscopic dilatation. As mentioned, if the patient has a depressed iron, depressed hemoglobin, you can diagnose it as Plummer-Vinson syndrome, and then you're going to go ahead and do the endoscopic dilatation, but you're also going to supplement the patient with iron. And so this is a web here. You can see these are both in the neck. Here's the patient's head right here. So this is the neck. This is the cervical vertebrae. And so you can see that this is clearly not a ring because there's no narrowing on this side. Same here. You got narrowing here, but no narrowing on this side. So this is a web. It would look like this. You've got the narrowing here, but no narrowing here. Okay, so now we're going to move on to more of the things that cause pain. And the first thing is diffuse esophageal spasm. So this is, like achalasia, this is a disorder of neural conduction. But unlike achalasia, what comes from this is a very painful spasm of the esophagus. And it's very, 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 very painful. And pain is going to be the number one presenting symptom for these patients, more than anything else. And this is intermittent pain. So this is not odynophagia. It's pain, and it's pain in the esophagus, but it's not odynophagia. Why? Because odynophagia is pain from swallowing. It's pain from food or saliva moving down the esophagus and irritating something. This is intermittent esophageal pain that can come on from anything. So you're getting spasms and it causes pain. It doesn't have anything to do with swallowing. So this is not odynophagia, but it is pain in the esophagus, but it's intermittent pain. And so the symptoms here are going to be intermittent pain. That's going to be the most prominent. And these patients will describe this as crushing, sometimes substernal. Sometimes they'll say it radiates to the back. And what does that sound like? That sounds like an MI. And so we always, 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 always have to rule out a cardiac cause. And I would say that the only exception to that would be a young patient who's otherwise healthy. So you got a 25-year-old patient, you're not going to be thinking about MI. But if you got a 60-year-old patient who comes in with crushing substernal pain that radiates to the back, you better bet EKG is going to be the first thing you get. Of course, exception to that might be if you have an aortic dissection, but that's a separate issue. You can go to cardiology to look at that. So the point I wanted to address here, though, would be that you got to keep in mind how you're going to triage what your possible differential is. If you have a patient that comes in with crushing substernal pain, you've got to be thinking cardiac before GI. Diffuse esophageal spasm is not going to kill you. MI could. So always work up your cardiac causes before you go on to work up your GI causes. But the history is going to help you. A lot of times with diffuse esophageal spasms, what you're going to get is a younger patient or a middle-aged patient who takes a drink of cold water and then all of a sudden they get this pain. That is not something that you would think of in an MI. So look at the history. As far as the symptoms, though, you've got to triage it appropriately. As far as diagnosis, if you have a presumptive diagnosis of DES, what you're going to get is, oh, this is wrong here. This should say with a normal EKG. So with a normal EKG, if you're thinking DES, then manometry is going to be the next best step in the diagnosis, and that will confirm your diagnosis. So with a normal EKG, manometry will be your next step in diagnosis, and that will give you your confirmation. The treatment here is going to be calcium channel blockers. Diltiazem is probably the most commonly used, but you can use any of them. Nitrates can be used, but the problem with nitrates is while it does work for most patients, it can worsen the pain in some patients. So we like to go to calcium channel blockers first, and preferably IV calcium channel blockers. Okay, so this is a barium esophagram of diffuse esophageal spasm, and barium esophagram is not our first diagnostic test of choice. It's going to be manometry. But the reason I put this on here is because you can visualize what this looks like. And now what you have in normally what you should have in your esophagus is a coordinated peristalsis. So you should have one wave that moves down to the stomach. So you should only have one little narrowing at a time. So it should move down. This narrowing should move down. You should only have one narrowing. You shouldn't have this sinusoidal looking esophagus. This is diffuse spasm. You're getting diffuse constrictions at various parts of the esophagus. Normally you would only have one. So this is the sinusoidal esophagus is what we'd see in esophageal spasm, and we diagnose this with manometry. All right, esophagitis is infection or irritation of the esophagus, and infection is rare in immunocompetent patients. So the trademark of esophagitis is odynophagia. Why? Because esophagitis is inflammation. Inflammation is going to be tender, it's going to be painful, and when you swallow something, swallow food, that's going to elicit the pain. So odynophagia, you should be thinking esophagitis. It can be caused by either an infection or irritation, and so history is going to be vital. If the patient has HIV or the patient has oral thrush, which is, you'd see like white plaques in the mouth, then it's safe to bet that the diagnosis is going to be candidoesophagitis because it's so common, particularly in patients with HIV, but it can also happen in patients, I've had it myself, it can also happen in patients who are on antibiotics. That's how I got it. They thought I had strep throat and they gave me an antibiotic and I wound up getting candidoesophagitis from it. Worst thing that could happen. So patients who are on antibiotics, patients who are immunocompromised, they can get candidoesophagitis. So if you have oral thrush or you have a patient with HIV, you're going to just jump right to treatment and you're going to give them fluconazole. You're not even going to bother with an EGD. If they respond to the fluconazole, you're done. It's candidoesophagitis. More than likely they will because it's so common. Now if it's a patient that's immunocompetent, they don't have HIV or they don't have any kind of immune suppression, or if it's a patient that doesn't have oral thrush, then you're going to do your EGD. So patients with HIV or oral thrush, candidoesophagitis, will give them fluconazole. If it's a patient that doesn't respond to fluconazole or they're immunocompetent or they don't have oral thrush, Then you're going to get an EGD. You're going to get cultures and biopsies, whatever you need, and you're going to treat based on the cause. So here's some of the different causes of esophagitis. We're not going to talk about the infectious disease behind this, but I do want to go over some of the treatments. With candidiasis, esophageal candidiasis, we're going to treat them with fluconazole, and that's going to be your patients that have HIV. We're going to treat them presumptively for Candida albicans, and your patients with oral thrush. As far as if they don't have, if they fail fluconazole, if they have HIV and they fail fluconazole, well, then you're going to do your EGD and you're going to get cultures and you're going to look for either herpes simplex virus, cytomegalovirus, or if it has neither. If you get herpes simplex virus, you're going to treat with acyclovir or ganciclovir, either or. With CMV, you're going to have to treat them with ganciclovir, or you can use foscarnet. The reason is because acyclovir does not kill your cytomegalovirus. So you need to have ganciclovir or foscarnet for cytomegalovirus. You can't use acyclovir, only for HSV. You can actually have, and this is one of the rare things, in patients with HIV, the actual HIV virus alone, normally it just affects blood cells, but actually in patients with HIV, the HIV virus itself can cause inflammation. And so patients who don't show up positive for HSV or CMV, you can actually diagnose them with directly HIV esophagitis. These patients, you're just going to want to get their CD4 cell counts up above 200. So you're going to continue their retroviral therapy. HAART is just highly active antiretroviral therapy. In the patients who are non-immunocompromised, some of the more common causes are, of course, Candida albicans. You're going to most commonly see this in non-immunocompromised patients with oral thrush. You can get caustic ingestion. This is going to be just supportive therapy. Of course, these are the patients that, usually kids who swallow lye or they swallow acid. These patients is primarily just supportive care. And then pill esophagitis is usually what happens is the patient takes a pill, they go and lay down, and the pill doesn't get all the way down. It causes irritation to the esophageal wall, and that's going to cause the esophagitis. With these patients, you're going, of course, you'll see this because you're going to, any non-immunocompromised patient that doesn't have oral thrush, you're going to be doing an EGD. And so if you see the inflammation just in one little place, you'll know that this is pill esophagitis. A lot of times you'll see the pill too. And these patients will just treat them symptomatically. We'll give them sucralfate, which is sort of a viscous coat for the esophagus, and then we'll give them viscous lidocaine, which is it blocks the pain directly, and then of course patient education. So these are some of the medications that can cause pill esophagitis. Alendronate and risendronate are the bisphosphonates. What these are prescribed for are generally older women with osteoporosis. So both of these you definitely need to take with plenty of water, and you cannot lay down after you take them for a couple hours. Doxycycline is an antibiotic, and this is particularly prescribed to patients with acne. So a lot of vignettes will talk about 16, 17-year-olds that have esophagitis, and so that's something to think of because doxycycline is commonly prescribed to kids with acne. NSAIDs, iron, vitamin C, potassium, and quinine can also cause pill esophagitis. So a Mallory-Weiss tear is a non-transmural tear, which means it doesn't go all the way through the esophagus. It's primarily restricted to the inner layers of the esophagus, and what it's caused by is a straining of the esophagus, usually associated with strong vomiting. And this is the most common cause of painless hematemesis. So I know I put this sort of in the classification of pain, and the only reason I did that is because a lot of these patients, even though the hematemesis was painless, a lot of these patients will be in pain because of the vomiting. Vomiting can cause pain in your stomach, and it can cause pain in your throat, but the actual hematemesis is not painful. So don't think of Mallory-Weiss tear as a painful thing. It's painless hematemesis, but it is generally followed by vomiting, which for some people is painful. So the history is strong vomiting, dry heaves, and then suddenly blood in the emesis. So classically, this is a patient who went on a night of binge drinking, they woke up, they're hungover, they're vomiting, they have the dry heaves, and then suddenly they're vomiting out bright red blood. That is a Mallory-Weiss tear. So the symptoms are hematemesis and sometimes melena. Melena would be more in the patient that had the vomiting a while back, or the tear was a while back, because of course it would take time for that blood to get to the end of the GI tract. And generally for diagnosis, you can usually make this diagnosis on history, but for confirmatory diagnosis, you would want to do an EGD to visualize the tear. And you would see a non-transmural tear. I don't have an EGD to show you this, but it would be a non-transmural tear, but you don't really need to treat this. This is self-limited. You can cauterize it if you want, but you really, in the first place, you really don't even need to go down with an EGD. It's really a diagnosis that's primarily based on history. Now, a thing that we're not going to talk about right here, because this is more a surgical disorder, is Boerhaave syndrome, and that is a transmural tear of the esophagus. That's going to be accompanied by significant abdominal pain. But this is a non-transmural tear, so you're not going to get any air in the abdominal cavity. And this is just the only reason this causes pain is because, or the only reason this causes a problem is because of the hematemesis. Otherwise, this is relatively non-consequential. Okay, the last thing I want to talk about is systemic sclerosis with GERD. So this causes dysphagia because you're having GERD with a certain disease process, but this is totally different from the other ones. So there's two reasons this is different. One, this is caused by another disease process. So systemic sclerosis or scleroderma is an autoimmune disorder, and basically what happens is that at multiple different sites, multiple different organ systems, what you get is a deposition of collagen tissue. And so it happens in the skin, it happens in the muscle, it happens in the small arteries, it happens in the kidneys. So therefore the history for diagnosing systemic sclerosis with GERD, or GERD secondary to systemic sclerosis, is going to be very, very reliant on the history. If you don't know that the patient has systemic sclerosis, you're going to just diagnose this patient with GERD. So you need to know that the patient has systemic sclerosis, so you have to know what the symptoms are of systemic sclerosis, which is what I described here. We're not going to go completely into systemic sclerosis because that's not a GI disorder. But if you know that this is a patient with a history of systemic sclerosis, or they have these kinds of symptoms, then you should definitely be thinking that the GERD is being caused by their systemic sclerosis. And what's happening is that you're getting collagen deposition inside the muscle of the lower esophageal sphincter. And so because you get collagen deposition inside that muscle's not going to be able to move, it's not going to be able to relax or constrict as it should. And so primarily the problem is going to be that the sphincter is not going to be able to constrict, and so you're going to have perpetual relaxation. And so if you have perpetual relaxation of your lower esophageal sphincter, it's going to be the opposite of achalasia. Remember, achalasia is where you can't relax, meaning you've got a constricted lower esophageal sphincter. This is the opposite. It's too relaxed. And so what happens is the contents of the stomach are going to splash up into the esophagus. That's classic GERD. But the thing is, this GERD is different, because this GERD is caused by a deposition of collagen in the lower esophageal tissue. And so the diagnosis here is going to be manometry. This is presuming you know that this is a patient with systemic sclerosis with GERD. GERD happens much more frequently in patients. The more common cause of GERD is not systemic sclerosis, it's idiopathic. But if you have a patient who has systemic sclerosis and they consequentially have GERD, then you're going to want to get manometry. And ultimately, you're just going to treat this as any GERD. You're going to use proton pump inhibitors, primarily omeprazole. And so these are the esophageal disorders, just kind of a recap here. And we'll move on to talk about some of the disorders of the stomach, particularly GERD, in the next few sections. I'll see you there.